And for those who are just joining us, Dr. Graham Lakkis, in addition to owning a private practice with clinical focus on eye disease, management and glaucoma treatment, Graham holds positions as a Senior Fellow at the University of Melbourne, Department of Optometry and Vision Science, and Lead Optometrist at the University of Melbourne Glaucoma Clinic. He's a member of the Optometry Board of Australia's Scheduled Medicines Advisory Committee and Optometry Australia's Glaucoma Clinical Practice Guidelines Group. Graham has lectured at both local and international conferences on the topics of glaucoma, ocular disease, and advanced clinical instrumentation. And his second session will be on visual field examination in glaucoma testing and interpretation. Welcome back, Graham.
Thank you. I hope my voice holds up.
Yeah, mine.
Alrighty. So this topic will sort of follow on a little bit from my previous lecture, and there'll be some slight overlap, but hopefully not too much. The purpose of this talk is to help you understand what the visual field testing parameters mean and what their relevance is to glaucoma, compare the different thresholding strategies so you can choose the most appropriate one. I'll go through sort of a refresher. Most practitioners know all this already, but to make sure we're on the same playing field, we'll talk about single field analysis and guided progression analysis as well, and then give you some tips for efficient scheduling of patients and practical recommendations to make your life and your patient's life easier. But I suppose let's start with an existential question. Do we actually need visual field testing anymore? Glaucoma clinical trials showed us that glaucoma diagnosis and glaucoma progression, so detecting progression, is typically found with one modality alone. You either find it through disc changes, or you find it through OCT changes, or you find it through visual field changes, but almost never do you find it with all three at the one time. So it's rare for diagnosis or progression to be confirmed with both structural and functional changes simultaneously. So then the question is, which is better to detect glaucoma and which is better to detect progression? Is it disc changes? Is it OCT? Is it visual field changes? And the answer is, it depends, like most things in life. So in Dana Bloomberg's study, they had patients that were newly diagnosed with glaucoma, and they looked at how did we find this patient had glaucoma? How did we make the diagnosis? So the red line is the disc photos. The blue line slightly above it is visual field. So visual field was found to be slightly better at finding glaucoma than disc photos, but OCT RNFL thickness was better than the rest of them together. So based on that study, you would say, maybe OCT is enough. That'll help me find most of my glaucoma diagnoses. In this study by Banegas, they were looking more at progression of glaucoma. Patients already were on treatment. Who was stable, where was the target pressure appropriate, and where were they progressing? And they found that to detect progression, again, disc photos came out the worst. 15% showed neuroretinal rim loss on stereo disc photos. About a third, about 32% showed progression with visual field loss, and about 2/3 showed progression only on RNFL. And that's what the Venn diagram is sort of showing us. 53 patients detected OCT alone, 24 by visual field, 7 by stereo photos. Only 3 patients in their study were detected on all 3 at once. So that shows us that detecting progression does not rely on simultaneous changes on all modalities. Often it's only one modality that changes. So 64% with RNFL is good, but that leaves out another 36% or so that weren't detected by RNFL, but were found on clinical examination disc photos or visual field losses. So OCT appears better than visual field for initial diagnosis and for detecting progression of glaucoma. However, about a third or a large minority deteriorate by fields alone. And if you only do OCT scans, you're going to miss those patients. As glaucoma worsens, visual field testing becomes even more important. When we have 5 or 6 ganglion cells helping us to see a point in space and we lose 1 or 2 of them, we can still see that point in space. But as we lose all our spare ganglion cells, then the visual field can deteriorate very rapidly after that. So in more advanced losses, visual field actually becomes more important than structural changes. So as I said to you in the previous lecture, the OAT study found the progression was detected mostly by disc changes, and the early manifest glaucoma trial found progression of glaucoma was detected mainly through visual field changes, not stereo disc photos. So that's telling us that once a field defect is present, progression is sometimes better detected through field changes rather than just disc changes, because you don't have those spare ganglion cells anymore. And these are the graphs I showed you in the previous talk. And again, it reinforces that changes by field and disc are very low compared to one modality alone. So yes, OCT is better than visual field, but diagnosis and progression analysis is better when we do both of them together. And this is a graph comparing the sensitivity and specificity of visual field alone for glaucoma diagnosis, OCT alone, and doing both of them works much better than OCT alone. So I hope I've made a case that visual field testing is still needed at all stages of glaucoma. In your glaucoma suspects, in the patients with early glaucoma, and the patients with advanced perimetric disease. However, patients don't like doing visual fields and practitioners don't enjoy visual field testing. So we need to develop strategies that minimize the inconvenience and maximize our clinical information. So you've got your visual field unit on. The patient's got one eye patch. They're sitting in front of the unit with a clicker in their hand. What's the best way to proceed? First thing we have to decide is how much of the visual field area are we going to test? Do we need to assess 5 degrees, 10 degrees, 25, 30 degrees, 60 degrees, 180 degrees? How much do we have to do? Typical perimeters will test out to about 30 degrees in a thresholding strategy. And the Humphrey, which is probably the most commonly used, has a 30-2. It tests 76 points in the central 30 degrees. So 30 degrees from fixation either side. So it's really testing 60 degrees overall. It covers a fairly wide area, but it has a longer test time because it's testing so many points. The 24-2 only tests 54 points, so it's able to get through the test about a minute faster. And in the part of the visual field where glaucoma tends to attack first in the nasal step area, it has 2 additional points out to 30 degrees. So it's not strictly a 24-2, it has a little bit of the 30-2 in it in a very important area. And then we also have the 10-2. It tests 68 central points within the central 10 degrees. The reason for that is studies show us that about 1/3 of patients at the time of diagnosis of their glaucoma have central or paracentral defects early in the disease process. The 24-2 and the 30-2 only test 4 central points, while the 10-2 does 68 central points. The downside to that, again, it's a very long test time and it's not involved in guided progression analysis, unfortunately. So it's hard to check for change over time with the 10-2. So here's a little diagram. The hollow dots are your 24-2. The points are actually at 3 degrees and then they go every 6 degrees. So it's 3, 9, 15, 21, and 27. So not quite to 30, but it gets called a 30 degree. The 30-2 are the additional points in that ring around the outside. And the 10-2 points are the ones that I'm showing in green within the central 10 degrees. And the red dots are the ones that are included in your standard 24-2 and 30-2. So most practitioners end up picking between a 24 or a 30-2 visual field. So which of those is better? Looking into all the published research, the NH and MRC consensus guidelines said that testing a 24-degree field often represents the best compromise between speed, patient comfort, and amount of reliable information gained. So in most cases, the 24-2 will give you the best data in the shortest test time for the patient. And another study from 1999 comparing the two strategies said, in most cases, the 24-2 provides information comparable to that from the 30-2 in a shorter test time and with less variability. What less variability means is that those outermost points, and I'll go back to them, sorry if I can find that image. Those outermost points there are harder to threshold accurately. They're quite variable because they're at the limits of the person's central field at the edges of the macular area. So the data you get from those is often highly variable and it's harder to detect change over time. They're what we used to call edge points in a visual field before we went to 24-2 testing. So at this stage, it looks like 24-2 is the best option to be using for visual field testing. But what about those central defects that occur in a third of patients? Traditionally, we would run an additional 10-2 test on anyone that was missing one of those 4 central points. But that required an extra visit, extra cost to the patient, and extra time for the practitioner. Researchers have shown that if you test 10 additional points, not 68 additional points in the central 10 degrees, in an arcuate type arrangement, that'll pick up most of those central and paracentral defects. And that's been released as the Humphrey 24-2 revision C. So they call it 24-2C, where C stands for central points. It adds about 30 seconds to the 24-2 test rather than adding 6 or 7 minutes to do a 10-2. And I've marked those points in red over the 24-2. So there's basically 5 additional points in an arcuate and 5 additional points in an inferior arcuate. What about the thresholding strategy? When perimeters first came out, when I was an optometry student, they used to do what's called a full threshold. There'd be a seen, unseen, and the gap between each of those steps was recorded, and it would often take 6 to 10 steps to find the threshold for a particular point, and a 30-2 field would often take 15 to 20 minutes to complete. It was really accurate. The threshold was really accurate, but the patient got so fatigued that all accuracy was lost due to poor concentration. So we don't tend to do full threshold anymore. Full threshold is done for 1 seed point in each quadrant at the start of the visual field. So it's not the innermost point, it's the next point out, the one at 9 degrees. It gets a full threshold done in each quadrant, and then that value is used to determine the value to start with the adjacent point. So you're not starting totally from 0. And that's called SITA, Swedish Interactive Thresholding Algorithm. SITA standard is quite precise. It still does a little bit of thresholding for the adjacent points and takes a little bit of time. It takes maybe 7 to 8 minutes to do a visual field map with SITA standard. SITA fast is quicker. It has a few fewer thresholding steps for each of the adjacent points to your seed point and a quicker test time. So which is better? Although SITA standard is a more precise testing algorithm than SITA fast, particularly at lower visual field sensitivities, it's unlikely to make a difference to improving the time to detect visual field progression. So basically, as your field gets worse, SITA standard works better than SITA fast, but in practical terms, it doesn't really gain us much benefit at detecting progression rate. Now, in recent years, in the last couple of years, we've got a new thresholding strategy called SITA Faster. It's available on the latest Humphrey 3 perimeter. It's not available on the Humphrey Visual Field 2, the older version. It's a software upgrade, and it's about 50% faster than SITA standard. The good thing about it is that if you've been testing on SITA standard or SITA fast, you don't have to establish a new baseline for your progression analysis. You can interchange between all 3 of those SITA strategies. So this data comes from Humphrey itself. So SITA standard 24-2 is 8 minutes. SITA faster is completed typically within 4 minutes. And in practical terms, it's actually much faster than that. And if you look at their data for normals, a patient without glaucoma, say a glaucoma suspect, they're finishing a 24-2 SITA faster in 90 seconds. So 1.5 minutes to about 2 minutes. If they've got glaucoma, it takes a little bit longer. So it's finishing in about 4 minutes, but some people can finish still not longer than 90 seconds. And the comparison, SITA faster to SITA fast, there's only 0.1 decibels difference in the mean deviation. And between SITA faster and SITA standard, again, 0.17 decibels. So they're very similar to one another. Sensitivity and similarity does vary, as we said, at near normal thresholds. So most people centrally are thresholding around 32 decibels. All three strategies are virtually the same. Even if they've lost 10 decibels, they're pretty much identical. When they start to lose 20 decibels, so around -20, then CETA faster becomes a little bit less precise, but all of them become less precise. As the visual field defect gets worse, they all become less precise, but CETA faster deteriorates a little bit more than that. Maybe then you can go back to CETA fast, which is the red dashed line rather than the solid blue line. But for most of the people you're working with, glaucoma suspects and early to moderate perimetric disease, which are between -6 to -12 decibels, they're going to do well with CETA faster. All right, let's talk about single field analysis interpretation, just to clear up any things that may have been forgotten. So these are the global indices. On your printout, we have an MD, which stands for mean deviation. That looks at the whole visual field and how different it is compared to an age-matched normal. So if you score a 0 on MD, that means you're exactly the same as expected for your age. And if you've lost everything and you're around -30, then you're pretty much blind or 30 decibels worse than age expected. However, mean deviation is affected by cataract, very small pupils. The ideal pupil size to do a visual field is somewhere between 4 to 5 millimeters in size. Smaller pupils than that will reduce the MD. And if you don't put the correct lens in front of the patient's eye, uncorrected refractive error will also affect the MD. So in my example to the right, this mean deviation is -2.8. So they're around 3 decibels worse than age expected. The pattern standard deviation looks at the variance of each point in the field from the patient's own hill of vision. So if their MD is -3, there are some points that are worse than that, and they are picked up by the pattern standard deviation. And that's shown here under PSD. And anything better than about 2 usually doesn't flag or might flag at the 10% level. It becomes more significant when it flags at the 5% level. So the higher that number means the presence of more significant scotoma that's worse than the overall generalized depression of the field that's shown by the mean deviation. Visual field index is what we mostly use in modern perimeters, is a combination of the mean deviation and the pattern standard deviation, and it weights the central points, which are more repeatable and more important to the, gives them more weighting than the peripheral points. And this is the figure I tend to quote to patients. So if I tell them your visual field is 100% intact, that means their VFI is 100%, and they can understand that very readily. If I told them your mean deviation is 0, they might think they've got 0 vision, even though mean deviation of 0 is actually perfect. So I tell them visual field index of 100, that means you're doing well. If it's 60%, I'll tell them, okay, you're starting to get into advanced visual field losses. The glaucoma hemifield test, as shown here outside of normal limits, compares clusters of points in one hemifield. So the average of those 3 points is compared to the average of the other 3. And then that cluster is compared to that cluster. The nasal step clusters are compared. The temporal clusters are compared. And if the averages are significantly different, the glaucoma hemifield test is flagged. So in the previous lecture, if you attended that one, we talked about glaucoma staging, and the categories are basically high-risk ocular hypertension, pre-perimetric glaucoma, early, moderate, and advanced perimetric disease based on the mean deviation and the visual field index. So here's some examples of an early perimetric glaucoma, typically in the nasal step area, but in the bottom diagram. This is a left inferior nasal step with a mean deviation of -5. This is a left superior arcuate, also with an MD of -5. And this is a left superior central defect and a small nasal step, all with an MD of -5. So they're all considered early perimetric glaucoma, except this one that's affecting central vision. And if those central points have lost more than 10 decibels within the central 5 degrees, which your 24-2C field should pick up, then that automatically becomes advanced glaucoma. Moderate has a mean deviation of -6 to 12 and a VFI of 80 to 60, and advanced disease typically has worse than -12 decibels of loss in the mean deviation, or worse than 60 degrees in the VFI, or central vision losses. So in this case here, we've got a central point here. That's at 3 degrees from fixation, that's lost 10 decibels. So that's a significant point if it's repeatable. So what is a significant visual field defect? You run the test, and now you've got to look at the printout. The problem with visual fields is that they're quite variable. They depend on patient performance. That's why they call them a subjective test. And differentiating random visual field losses from true early glaucoma is actually quite difficult. So the way we work out what's random and what's not is by doing repeatable tests. And if the defect is repeatable 2 or ideally 3 times in the same location, you're pretty certain that that's a true defect rather than just the patient having a bad day. So what are significant defects? If you have a cluster of 3 or more points in the same hemifield that is at a higher probability, then that's likely to be significant if it's repeatable. Reading it out makes no sense, but looking at the picture does. So this is a cluster of 5 points in the same hemifield that I've put in a red box. If one of those points is in the 2 darkest grays of probability, the 1 or the 0.5%, then that's considered a significant cluster. If they were all in the 2 lighter colors, the 5 and the 2%, that wouldn't be significant yet. We need at least one of those points to be in the darker of the 2 colors to make it a statistically significant cluster. So in this example, yes, that would be a left inferior nasal step if that was repeatable. And if you look at the actual data, those 3 points will probably end up needing to be less than -10. So you need about a 10 decibel loss on your pattern deviation data. If the PSD is flagged at 5% or worse, like this case I showed you before at 5%, and that's repeatable, then that's considered a statistically significant visual field defect. And if the GHT is flagged and is repeatable, then that's also a significant field defect, especially in one hemifield, which is typical of glaucoma. Typically affects one hemifield at the time of diagnosis. What's not good for diagnosis is mean deviation. It'll miss shallow scotomas, it'll miss early scotomas, because sometimes the better hemifield on the other hemifield drowns out the losses from the early scotoma, and mean deviation often misses early glaucomatous defect, so it's not used for diagnosis. But it is used for staging and progression analysis. Alrighty, you've made your definitive diagnosis of glaucoma. You've set your target pressure at 30% reduction, as we talked about in the previous lecture. You've started your latanoprost glaucoma drop. The patient comes back at 4 to 6 weeks and their pressure is at target. You reach around, you tap yourself on the back and say, job well done. Not yet. You can't pat yourself on the back yet, because the purpose of glaucoma treatment, as I said, is not to reach target pressure. The purpose is to stop disease progression, because target pressure is an estimate of the pressure that's going to keep that optic nerve safe, but no one can truly know the safe pressure. So the only way we know if the patient is stable or not is to regularly retest those 3 things we talked about at the start of this lecture. We have disc photos, we have OCT scans, and we have visual fields tests. And if we find deterioration in one of those tests that's repeatable, then that patient is deteriorating and we need to reset our target pressure by another 10% lower. However, if things are stable, the target pressure is safe and appropriate, and you can continue on as you are. Since this is a visual field lecture, I won't talk about progression of discs and progression of OCT. We'll talk about progression of visual fields. As I said, visual field testing is subjective and variable. It makes it difficult to detect glaucoma. It makes it even more difficult to detect progression of glaucoma. Patients who are poor test takers are highly variable. So if you repeat the field test the same day or the next day or a week later, and you get different MD, you get different PSD, you get different threshold at each of the points on the test, it's going to be harder to work out if the patient's truly progressing or if it's their inherent variability as a poor test taker. However, the statisticians and the mathematicians and the visual field researchers have worked out strategies to make our job easier as clinicians. What they found is that we need to take 2 to 3 reliable baseline visual fields fairly close together at the time we start seeing the patient for glaucoma management. That gives us baseline global indices, and it gives us a baseline measure for the sensitivity of each of the 54 points in, say, a 24-2 field, or each of the 64 points in a 24-2C. And it tells us the error bars of each of those points, and that tells us the patient's retest to test variability. Baseline visual fields, for that reason, have to be taken close together in time. So the changes are due to the patient's performance, not the disease getting worse. And then the statistical analysis software works out if the progression is statistically significant or if it's not. You can't just look at the data. The software has to work it out for you based on how much progression happens with age and how much progression is due to, how much variability is due to the patient's variability. Now, most modern perimeters have progression analysis software. The most studied is the one from the Humphrey Field Analyzer called Guided Progression Analysis, or GPA. GPA uses two methods to detect progression. One's called event analysis and the other's called trend analysis. Event analysis looks for changes in each point on the visual field. So if you've got a scotoma at the time of diagnosis, it looks for a deepening of that scotoma. Maybe that point was -10, now it's become -16. That's a deepening of an existing scotoma. It looks for widening of a scotoma. So if your original nasal step was 5 points, as I highlighted in that red box previously, and now it becomes 7 points in the scotoma, that's a widening of an existing scotoma. It also looks for a new scotoma developing. So if your patient has, for example, high-risk ocular hypertension, they don't have a visual field defect, or they've got preparametric glaucoma, they don't have a visual field defect, and they now start to develop one, the event analysis will pick that up for you. The mean deviation may not pick it up. So it's based on the pattern deviation plot, not the MD or the VFI. It flags points that have changed more than the patient's test-retest variability. Now, for that to work, you need 2 or 3 baseline exams and 1 follow-up exam, and it'll show you which of those points are worse than the baseline. However, that third visual field test, for example, the patient may be having a bad day. It really can't tell you truly if a person has progressed. What we need to do is to show that point in the visual field has worsened 3 times in a row from the initial baseline, and then it becomes highly statistically significant and it's less of a false positive. The other thing to point out is event analysis tells us when or if progression has occurred. It doesn't tell us the rate of progression or how fast the patient is progressing. So let's give you an example. I haven't shown you the full printout. This is just the last plot on a GPA for event progression. It shows you the latest visual field and the latest global indices. So their visual field index is 77% with a mean deviation of -8. So you would call that moderate parametric glaucoma, and it's got a marked superior nasal step, left superior nasal step, and an early inferior nasal step. Now, how are they compared to the baseline? We go to the end of the chart. The points that haven't changed since baseline are given with a small dot. The points that can't get any worse than baseline because they were severely damaged at baseline are given an X. And basically the statistical software can't analyze them. They're so bad to start with, they can't statistically get more worse than they already started with. So they're given an X. It's the ones in between that tell us how much event analysis has occurred. If a point has a hollow triangle, it means it's statistically confident that it's 95% worse than baseline at one particular visit. If that same point is worse again, it's got a 95% probability of being worse than baseline 2 tests in a row. And if it's 3 tests in a row, it gets a whole solid triangle. So that point here at -8 is 8 decibels worse than baseline, but only on this particular test. This point adjacent to it is -4 decibels worse than baseline, but it's been worse on 2 tests in a row. And this point here is only 5 decibels worse than baseline, but it's been 5 decibels worse 3 tests in a row. That's why it's in a solid triangle. If you have 3 solid triangles, the software will say likely progression, and that means it's 97.5% sure that the patient has truly progressed. If you have a mixture of, say, one solid and two half-filled triangles, it'll say possible progression in orange. But generally, we don't alter management based on that because there's almost a 20% false positive rate with those. And some of those triangles will actually go back to dots at the next field that you do. So wait till you get something that says likely progression, then you know that they have progressed based on event analysis. Again, it's confusing trying to read it out to you, but in real life, it's actually fairly easy. The software will tell you when the progression has been significant, and you can tell where it's been significant. So we can see that left superior nasal step has worsened significantly. The left inferior nasal step is starting to worsen a little bit in that area. So it tells us that progression has occurred and where it's occurred. It doesn't tell us how fast the rate of progression is going. That's what we have trend analysis for. It looks for progression over the entire visual field, not in each point. And therefore, it has to use a global index. It uses mean deviation or visual field index. It requires, similar to event analysis, it needs 5 or 6 reliable visual fields for the software to do its calculations. Trend analysis gives us the rate of progression. How fast is the field deteriorating? It doesn't tell us where in the field they're deteriorating. That's what event analysis is for. The rate of progression can actually predict future visual field loss and the time for the patient to become blind. So let's give some examples. On the image on the left, this is an earlier printout when mean deviation was being used in the software before the latest perimeters. And it shows us the patient starting at normal, 0 mean deviation. Their first field, they had about -3, 3.5 decibels of loss. The second field, they did a little bit of it. They had an MD of -2.5. Then it dropped to around 5. The next one was 5. Then it dropped to 6. Now it's dropped to 7. The software puts a linear regression line in, and it says that patient is losing almost 2 decibels per year. So we know in 10 years, they're going to lose 20 decibels. So at the moment, they're about -7. And by the time 20 years has passed, 10 years have passed, they've lost 20 decibels and they're going to be -27 or basically blind. So that lets us know what's going on. With the newer software, they use VFI, which is less affected by the formation of cataract. And they can actually plot out the patient's age for you and show you what's going to happen. So in this patient, they're losing 3.7% of VFI per year. And it predicts that at the moment, they're around the high 70s, around 75%. So that's moderate perimetric glaucoma. In 5 years' time, they're going to be below 60%. They're going to have advanced disease. So you really need to intervene to slow down that progression rate if you can. And in the picture below, this is a real bad case. The person is losing around 10% a year, and within a short space of 3 years, they're going to be totally blind. So already in a short space of time, they've gone to 60 to 40%, and they're going to lose their remaining 40% in a short space of time, unless we can intervene, get their pressure low enough to stop progression. So VFI, as I said, tells you the rate of progression, not where it's occurring, but it helps to predict the future for you. And the guided progression analysis printout gives you both of those every time. Once you've done your 6 visual fields, it'll give you both of those images. So you'll get a GPA after the 3rd test, but it usually won't have statistical analysis. It doesn't have enough data to do that. So after the 6th field test, they'll give you an event likely progression and a trend rate of progression. So ideally, before we can make a decision about that patient that we're treating, whether they're stable or not, we need to have 6 visual field tests done to statistically determine if progression is occurring. Now, 6 is sort of the best case scenario. Sometimes we require even more tests because some tests have high false positives or high fixation losses, and the software actually won't analyze them. So sometimes I'll go to look up the GPA for a patient, and I'll have it for the left eye, but not the right eye, because they might have had high false positives and they don't have the 6 fields you need for the right eye, but they've got the 6 you need for the left eye. So sometimes we need 8 or 9 or even 10 fields before we'll get the statistical analysis in poor test takers. So as the clinician, we want to detect progression at the earliest opportunity before the patient loses too much of their visual field. So ideally, we want the 6 visual field tests to be done in the shortest time possible. Hope that makes sense. However, because glaucoma is typically a slowly progressing disease, we need to allow enough time for the disease to progress, because there's no point doing a field this week and then doing one every Monday for the next 6 weeks. Yes, the software will say no progression, but the disease hasn't had even enough time to progress. So there's no point doing it that quickly. So what's the optimal time? Before we had this robust statistical analysis, the earlier clinical trials used to run for 5 to 7 years because it took that long for them to detect visual field progression. However, studies coming out since, say, 2013, like the UK glaucoma treatment study, for example, were able to find statistically significant progression in about 2 years. And that's where a lot of this data is coming from those studies that are run by statisticians, not by optometrists and ophthalmologists. And they've been able to detect clinically and statistically significant progression within a period of 2 years. So based on that, the latest clinical guidelines coming out from the European Glaucoma Society say that if you've diagnosed someone with glaucoma, you need to have 6 visual field tests in the first 2 years after starting treatment. That allows the progression rate through trend analysis to be determined in about 2 years if you have a good test taker, and about 3 to 4 years if the patient is a more variable test taker. The aim of progression analysis is to find patients that are losing more than 1 decibel a year, because those patients are the most likely ones to be rapid or catastrophic progressors and then go on to becoming blind. The ones that aren't progressing much, they can stay under your care for the rest of their life and they're not going to run into too many problems. So based on Chown's work in the late 2000s, they came up with this table. And it looks a bit confusing, but I'll highlight what we're looking at. We want to find patients that are losing more than 1 decibel of mean deviation a year, which is this column here. I'm not worried about the 1/4 decibel. They're not going to run into trouble. I'm looking for the ones that are losing 1 or maybe 2 decibels a year. If I do 1 visual field exam a year and the patient is a good test taker with low variability, it's going to take me 6 years to detect that patient. So it takes 6 years to get 6 visual field tests so the software can do its calculation. And in that time, the patient's lost 6 decibels. So if they started with early parametric glaucoma with a -4 defect, now they become a -10. They've lost a lot of visual field before you've detected the progression. And if they're a more typical poor test taker with high variability, it takes 13 years to detect that patient doing a field test every year. And they can go from early disease to severe parametric glaucoma and advanced vision loss by the time you've statistically detected their progression. What if we increase that to 3 exams per year? It now only takes 2 years to detect your rapid progressors in a good test taker, or 4 years in a highly variable patient. So yes, you say 4 years is still a while, but they've only lost 4 decibels compared to losing 13 decibels, which is a much better scenario to be in than doing a test once a year. And doing 2 exams a year is better than 1, but not as good as doing 3. Alrighty, so now we know that we need to do 6 visual field tests in the first 2 years and why we need to do it. So in patients with glaucoma, how fast does visual field typically progress? It's measured in 2 units, like the same way we measure mean deviation and visual field index for our global indices. It's measured as loss of decibels per year or loss of percentage per year in the VFI. They've gone into the 5 major ophthalmology hospitals in the UK and tested thousands and thousands of patient clinical records, and they found that the average rate of visual field loss in patients that are on glaucoma treatment is virtually 0, negative 0.06 decibels a year. So that means in 10 years, they'll lose 0.6 of a decibel, which is negligible. Virtually 0 progression. That's really reassuring. Most patients with glaucoma can be stabilized really well. About 1/3 of patients were actually found to improve from their baseline. And I found that in quite a few of my patients. And the theory for that is that they're learning how to do the test better. They're picking up those really faint points on the visual field test better and realizing they're not just nothing in the background. There's other theory that if you treat glaucoma early enough, some of the sick and malfunctioning ganglion cells actually come back to life and start having a bit of extra sensitivity. So it could be a combination of those two factors, but about a third of patients actually get better than their baseline field, which is another reassuring sign. What about the ones that get worse? Patients that do better than 1 decibel a year, which I've shown on the right-hand side of the graph in the darkest grey bars, they're considered slow progressors. And if you see the peak of the curve, most of them are around 0 progression, about a third are positive, and the rest of them have a bit of slow progression, not rapid progression, a bit of slow progression, less than 1 decibel a year. And most of glaucoma is diagnosed in older age, and they're usually not going to get into any trouble. What about the people in the next section? They're called rapid progressors. They're losing worse than 1 decibel a year, and they account for about 4.5% of the patients being treated for glaucoma. And then, I love this terminology, catastrophic progressors. That terminology leaves no doubt. These patients are in big trouble. They're losing 2 decibels a year. Thankfully, they only contribute to about 1 to 1.5% of glaucoma patients under current treatment. So that's why with our progression analysis, we're trying to find this category, the ones that are worse than negative 1 decibel a year. So with a positive slant, most glaucoma can be well stabilized with treatment, but not all people are totally stable. Some people progress very slowly, they won't have any issues. Some progress very rapidly and can lose a lot of vision in their lifetime. Okay, so we need 6 field tests in the first 2 years. Doesn't matter how they're spaced. You've got options. You can do your 2 baselines, then do 1 visual field every 4 months. You can do your 2 baselines, 1 visual field every 6 months, or you can do 3 baselines, then wait 2 years and do another 3 baselines, which doesn't sound very intuitive, but it actually ends up being the best option at detecting progression. So this is the statistical data. If you want to find your catastrophic progressors that are losing 2 decibels of mean deviation per year or worse, if you do 6 monthly spaced visual fields, you're only going to find about half of them. If you do them at 4 monthly spacing, you're a lot better. You'll pick up 80% of them. But if you cluster your visual fields, if you do 3 at the baseline and 3 after 2 years, you're going to pick up much more of them. You pick up about 95% of them with a minimal false positive rate. The other false positive rates are pretty good as well, but you've got a lot of false negatives, ones that you're missing out on that have progressed, but the software isn't unable to detect the change. Well, if you do your clustered visual fields, you have high detection rate and minimal false positive rate. And the reason for that is if you're spacing visual fields every 4 to 6 months, for example, the variability is the variability due to the patient's performance or is it due to the glaucoma? The statistical package can't work that out. But if you do them close together, there's no way the glaucoma has progressed in that short period of time. The variability is due to the patient. You can compare that variability to the variability 2 years later, and the software can do a linear regression much more accurately and find the true rate for you much better than with spaced visual fields. So it's strictly due to statistical analysis. Visual field testing is disliked by patients and disliked by clinicians. I know that personally. Anyone who treats glaucoma knows that. So because of that, we need to implement visual field testing that's quick, efficient, and not onerous on the practice or the patient. It's also to be noted that it's difficult to change clinical practice habits. So we have really good research that putting patients on aspirin to prevent heart attacks and strokes when they have never had one before actually doesn't work. Yet practitioners, medical practitioners, general practitioners still have people on aspirin, even though the trials show it doesn't work. It's really hard to change clinical practice habits. And the same with optometry and ophthalmology. Are practitioners that treat glaucoma following these new guidelines that have come out in the last 10 years? And those guidelines specifically regarding 6 visual fields in the first 2 years. In the UK, to put it in perspective, only 3% of optometrists are therapeutic prescribers, while in Australia it's probably 70% or more. So glaucoma is predominantly treated by the National Health Service, NHS, in ophthalmology hospitals and private practice. A study by Fung found that not one patient was examined in compliance with European Glaucoma Society guidelines. So they looked at 90,000 patients in the hospital system, and not a single one had 6 visual fields in 2 years. In fact, the average was only 2 visual fields in 2 years, i.e. 1 per year, which is that useless one that I was telling you about that won't detect your rapid and catastrophic progressors till it's too late. So again, we're not talking about poor practitioners. These are ophthalmologists in teaching hospitals, not following guidelines. Dave Crabb's multi-center audit showed that the average number of visual fields performed is still once per year. Again, useless. And in his conclusion, he said, doing the odd visual field test in every patient once or less per year is as useless as not doing it at all. So if you're going to do visual fields, do them properly. Don't do them infrequently. And they looked into the reasons why the recommendations weren't followed. And they surveyed patients and they surveyed the doctors. The reasons patients didn't like coming for visual fields, they don't like the test itself, they don't like the test environment. They found that they weren't secluded enough. There were people walking past them, there were noises and lights going on. They felt distracted. They felt that the person running the test gave them poor quality instructions and at the end failed to explain the outcome of the results to them. And when they had to do visual field tests, there was excessive wait time. So they'd see the orthoptist, for example, then had to wait for an hour for the visual field test machine to be clear and then wait another hour to see the ophthalmologist for their new prescription drug. So they hated doing it for all those reasons. When they asked the doctors, the clinicians said in one sentence, the new protocols are impractical. That was their reason. So what we know from this, that we need to do quick, easy visual field tests that are done frequently, much better than doing a really precise test infrequently. So you're much better doing a CETA faster 24-2, for example, and doing it every couple of months initially and then after a couple of years of treatment, rather than doing a full threshold that takes 20 minutes and doing it once a year, which is much more useless, or a CETA standard doing it once a year. If you do that, the patients like it better and you'll like it better because you'll get better clinical information. You're not going to miss those rapid and catastrophic progressors due to better statistical analysis. So let's finish with some practical recommendations. I'd suggest for most patients you see, use the 24-2C test pattern. That should be predominantly the only test you're using. If you've got the old Humphrey, you have to use the 24-2. And if they're missing any of those central points within 5 degrees, then you need to do a 10-2 separately. But for everyone else, use your 24-2C. Use the CETA faster strategy. That's the one that can finish in 90 seconds to 2 minutes. In practice, I find the 24-2C takes about 2.5 minutes in a person with glaucoma and about 2 minutes in a glaucoma suspect or someone with a near normal visual field. So they're my real world times, about 2 to 2.5 minutes, which is tolerable per eye for most patients. Do the test at month 0, 1, and 2, and then do the test at month 22, 23, and 24. The software will tell you the progression rate. Anyone who's a rapid or catastrophic progressor needs to be referred to a glaucoma surgeon as quickly as you can so they can intervene. And the remainder, which are 95% of the patients, can stay under your care and you can continue managing them with your topical therapy and all those things that we talked about in the first lecture, like SLT and MIGS. Thank you.
And bang on time. Thank you, Graham, for that lecture on visual field testing and analysis. First question right off the bat, let's get straight into it. Somebody's saying most optoms still have Medmont. Can Graham please comment on comparing the Humphreys Field Analyzer and Medmont, the different paradigms and establishing progression?
So I was a long-term Medmont user, but in 2015, when the Humphrey Field Analyzer 3 came out with some of these new software tools, I've switched over. So I'm really not an expert to see what improvements have been done in the Medmont in the last seven years. Things I liked about the Medmont were you can make your own testing patterns quite easily in the software.
Yeah.
So you can actually go in and recreate a 24-2C yourself in the software and run it that way. I know the progression analysis software in the Medmont was able to look at quadrants as well. and different sectors and see if there was more progression in the superior nasal step sector. So I think all perimeters do have software. It's just that the Humphrey one seems to be the one most researched, and that's why you find all of this data coming out. I think if you read the manual to your tools, use it to the best of your ability, and look for statistically significant progression, you'll be able to use any of the perimeters.
Yeah, I think you're right. Yep.
These things will apply. Doing an infrequent Medmont is as bad as doing an infrequent Humphrey. Doing a quick Medmont 6 times in the first 2 years is the best way to find progression with any perimeter.
Yeah, I think some of us are just hardwired not to read manuals. I think that's good advice overall, just in general, as a life rule. Look, while we're on the differences in field analyzers, somebody's asking any thoughts regarding the performance of FDT versus SAP perimeters?
So I think it was in the first lecture I showed the glaucoma continuum from Rob Weinreb, which looked like a rainbow. And one of the earliest type of visual field defects were found to be selective, what were called selective ganglion cell losses. So the FDT perimeter was looking at an earlier way to detect glaucoma than standard achromatic perimetry, or SAP, or white on white, by targeting the frequency double in ganglion cells. And the Humphrey was doing that with the blue on yellow, which was targeting the least common ganglion cells, and the Medmont was doing it with flicker perimetry. So it would flicker the LED to try and find losses in flicker-sensitive ganglion cells ahead of standard white on white perimetry. So those things are to detect glaucoma earlier. Unfortunately, or fortunately, I should say, now that we have OCT, those things have fallen by the wayside. So we don't need to do selective perimetry when we've got OCT to detect it even earlier.
Yep.
So most ophthalmologists don't do blue on yellow testing. Most optometrists I know don't do flicker or FDT. If they're managing glaucoma, they do white on white perimetry. They do OCT. However, if that's your only perimeter, FDT is good at detection, but maybe not ideal for ongoing progression management.
Yep. Okay. Graham, somebody's asking about, well, there's a few questions about item 10940. One of the questions is, 10940 is specified as threshold visual field. Is theta faster still claimable as a 10940?
Yes, so it's still thresholding. It's just the number of steps to get to the endpoint is shorter. So a full threshold might take 8 to 10 steps to determine the value. A CETA standard might take 6 steps. A CETA fast might take 4 or 5 steps. The CETA faster takes 3 steps, for example. It's still a thresholding. And the purpose of thresholding is to give you a figure for that point in space. It'll say 0, -5, -10, -15. It's not a seen or unseen like a binocular estimate for a driving test.
Yeah.
It's actually still thresholded. So yes, it meets the requirements.
A few questions on the 3 tests. Thank you, Amy. OA is well and truly aware that visual fields should be done 3 times a year, and we wish we could get a rebate 3 times a year. So that's certainly an uphill battle, but taken on board. Thank you, Amy, for that. Someone's asking, should the 3 tests be done in a specific period? Should it be within a week, 3 weeks?
It's variable. I know up in Sydney at the Centre for Eye Health, they're doing their 2 baselines on the same day, because it's only taking 2 minutes an eye. They're doing a right eye, left eye straight after each other and getting the 2 baselines on the one day.
And you're billing 2 940s for that on the same day?
No, I don't. I believe Centre for Eye Health is a public thing funded by the guide dog, so I'm not sure their billing arrangements, but I think that would be difficult to bill both on the one day. But they're saying that, we're doing, say, 10 minutes of testing and getting both eyes done on the same day. I don't tend to do it that way. I'll tend to do it after 2 to 4 weeks. Typically, for example, if I'm starting a patient on a drug, I'll test them when they start when they're a glaucoma suspect, I'll test them when they start their medication, and when they come back in a month's time to see if the drug's working, then I'll test them again. So I tend to do it that way. So the disease will not have progressed in that 2-month period.
Yep, no, that's fair enough. And while we're on the three tests per year, there's a couple of questions from different people about how obviously you can only get the 2 under 940. So what advice do you have for the viewers, our audience, around sort of covering costs and those sorts of things for the charging for the third one?
So for modern glaucoma management, OCT is pretty much mandatory. That's not covered by Medicare at all for optometry or ophthalmology. So patients have to pay out of pocket for that. So they might be charged $50 or $60 or $80, depending on the practice location and their chair costs. And the third visual field is the same way. We'll tell patients that you're covered for 2 tests, but in the initial 2 years of your treatment, we need an additional test, and there's a fee of $59, for example, for that test.
That's fair. I think that's a nice way to phrase it. We have a question here about trigger-happy patients who keep clicking and repeatedly have high false positives and fixation losses despite repeated instructions and having to restart the test. Any advice on that?
If you've given them the simplest test possible and tried to express the instructions in different ways that they may understand better, and you still can't get a reliable visual field test result, then unfortunately you can't rely on that data. And sometimes there are cases where we can't. For example, I like macular GCC for monitoring progression with OCT. If a patient has AMD or develops a choroidal neovascular membrane or an epiretinal membrane, suddenly macular GCC is useless to me. I have to rely only on RNFL. And if they have a problem with RNFL where I'm getting highly variable data because of a tilted disc or something like that, I can't rely on that. I have to rely on something else. So that's why we don't rely on one factor only. If you can't rely on visual field and you've tried your best, then you can't. You have to rely on some of your other factors like disc photos, clinical examination.
Makes sense. If they're not reliable, then they can't be considered as part of the gamut of data that you're inputting into that.
You can't rely on it. Therefore, you can't make clinical decisions based on that. I heard once an ophthalmologist say you can't get a 6.6 visual field result out of a 660 brain. So he said some patients just can't do a visual field, and you just can't do it.
Yeah, that makes sense. Look, let's take one more. This is the one that I'm keen to hear your thoughts on as well. Somebody's saying, what are your thoughts on the MRF, the Melbourne Rapid Fields platform, so patients can perform as needed at home? What are your thoughts on that, if you can share your thoughts?
Okay, so again, I haven't personally used it. I know the test because it was developed at the University of Melbourne, where I am, with Algie Vingras and George Kong from the IND Hospital. The purpose of the test was to do even more frequent field testing, so the patient can do it at home every week, and the data can then be downloaded through subscription to the practitioner, so they can make even earlier decisions on how stable the patient is. I find that if you follow the 6 fields in 2 years paradigm, you're really not going to miss those rapid and catastrophic progressors anyway, and you control your environment a bit better. So we know the Melbourne Rapid Fields is being done on an iPad. What are the room surroundings like in lighting? How far away is it held from their face, etc. There's a bit more variability in that. While if you're there supervising the patient, you have a better chance of making sure that things are being done correctly and fixation is being maintained, etc., etc. So I haven't found a great need for it. Same with eye care home tonometry. I bought the unit, but haven't actually had a case where I've really needed to send someone home with them.
Okay.
To try and find spikes of pressure that are happening outside of office hours. So that's my thoughts, but doesn't discount the technology. It's maybe the way of the future.
Never know. Look, we've got about a minute, so we're going to rapid fire one more at you. The question is asking about NHMRC regulations, but I think they mean OBA regulations. When are we required to on-refer to ophthalmology for treatment or co-management? Can you have a quick comment on that?
Okay, so from my understanding, the ophthalmology, the APRA OBA rules state that at the time of diagnosis, at the time of initiating treatment, within 4 months of initiating treatment, the patient needs to be referred or offered a referral to see an ophthalmologist. It doesn't state anything about progression analysis. It doesn't state that you must enter a co-management relationship, for example. After that initial referral, you can continue managing the patient. And if you find that they're progressing and need to be seen by the ophthalmologist, then you can make that based on your clinical decision-making. It's not mandatory. And it's like all other eye diseases, you get to choose when it's time to refer.
And presumably if the patient says you offer the referral and they say, no, I'd rather continue to see you if you can, then you have a duty of care, if you can, to continue to manage that patient.
Absolutely. They're under your care, and either you're going to have to manage it or someone else is going to have to. You can't just abandon the patient. You have a duty of care. If they prefer to see you, that means they've elected to see you, and there's no reason you shouldn't keep managing them.
Dr. Graham Lakkis, one of the eminent experts on glaucoma and visual field testing in Australia, we thank you for your time on this Sunday morning. We appreciate all the presentation, the details, how articulate it has been. And I think, well, I can vouch for everybody online has said that they've really appreciated and learnt a lot over the last 2 hours. So thank you so much for joining us over the last 2 hours for this glaucoma stream at Optometry Virtually Connected. For everybody online, we have a 15-minute break before we go into our Vision Eye Institute sponsored session with Dr. Crystal and Dr. Rushmia on the pediatric eye exam that will commence in 15 minutes. So quick chance for a break before we're back online with you for that next session. Thanks, everyone.
Thank you.